Hi, everyone. Can I just get some confirmation that everyone can hear me? Great. I'd like to welcome you all to this Hopkins Hour, which today the topic is very relevant for this month because this is Health Literacy Awareness Month. So the topic today is health literacy and rehabilitation. It's everyone's business. I'd like to extend a warm welcome to all Hopkins Centre members, partners and collaborators who are joining us today. I'll begin by acknowledging the traditional custodians of the land on which we meet virtually today and pay my respects to elders past and present. I'm coming to you from Woolloongabba, which is believed to be a Yagara word that means place of whirling waters. The Hopkins Centre encourages all attendees to learn about and learn from the traditional custodians of the land on which you live and work. I'm Delina Amsters from the Spinal Outreach team. And the Spinal Outreach team is part of the Queensland Spinal Cord Injury Service in Metro South. Today I'll be joined by Rhonda Beggs, Holly Booth, and a couple of clinicians, Amy and Julianne from the Acquired Brain Injury Outreach Service and the Spinal Outreach team. And together we're going to present about various aspects of health literacy. A little bit of housekeeping before we get started. Online environments are obviously going to vary. So if you're having any technical difficulties, just put a question in the chat via the toolbar at the top of your screen, and one of the events team will do their best to try and help you out. If you're having problems, you can leave Teams and you can come back in on the platform to see if that helps your connectivity. You can turn on captions via your Teams meeting settings by clicking on the three dots on your toolbar, then selecting language and speech, then live captions. And throughout today's presentation, please use the chat function to ask questions at any time throughout the session. So go to the top level of your Teams navigation bar and select chat, and this will open the panel. And I will be notified as your questions are coming up, and we'll attempt to answer as many as we can as we go through the event, or we'll share responses after. So away we go. First, I want to give you some overview. Oh, my camera. Now you're supposed to be able to see me in that space there, the green space, but unfortunately, for some reason, I am not coming up, which is a little concerning. Anyway, you're not going to get to see my face. Health literacy, it's everyone's business. And I hope by the end of this presentation, you're going to agree with me that it is everyone's business. So a quick overview of what we're talking about today. I'm going to give you a very brief introduction to health literacy and how it relates to rehabilitation and the rehabilitation project. I've got Rhonda coming in later to talk about easy read materials and how that differs from plain language. Holly's going to give us a quick tutorial on how MS Whiteboard can be useful in clinical communication. I'm going to give you a quick overview about how to do better emails for clinical communication. And finally, I'm going to have that chat with Amy and Julianne, and they're going to give us some insights about their health literacy learnings. So away we go. What's health literacy? Well, in a nutshell, health literacy is the ability to find, understand, assess, and use health information. So finding the information is one thing, but importantly, higher level of health literacy is about understanding and assessing whether the information is right and fit for the individual, and then putting it into some use. Most people think about written information when they think about health literacy, and I think that's got to do with the word literacy. So you think about people's ability to read, and of course, there is a lot of health information that's transmitted by written word, but also probably some of the most powerful health information transfer is through verbal transfer. Of course, we've also got things like signs and symbols. And really, when it comes down to navigating around health environments, these signs and symbols are very important. But there's also signs and symbols that appear in health information that need to be interpreted by people. And we've got an awful lot of audio-visual material that people are accessing and that health professionals are creating that is information about health and health conditions and rehabilitation, which requires an amount of health literacy to unpack. So I just want to think about health literacy now in the typical way that it has been thought about in the past. And then I'd like to just turn it on its head. Just bear with me. So typically health literacy is and has been conceptualized as individual people's skill to interpret the information, to find, access, interpret and use information. But now we're really very clear that the health system complexity and the complexity of information plays a huge role in people's health literacy. And we refer to this overall as a health literacy environment. So very much like we've moved along our concept of people's experience of disability, not just emanating from their impairment, we also understand that people's health literacy emanates from their context and their environment. And this is where we can play a huge role. So another way of thinking about health literacy is not people skills, but the health system skills and understanding people's complexity. So that's really the contemporary way of thinking about health literacy. This brings me to a term that I want everybody to remember from this presentation, if nothing else, and it's health literacy responsiveness. Being health literacy responsive is what we can all be as we endeavour to be part of that health literacy environment for our clients. Health literacy and clinical communication, so the things that we do in our communication, they're inextricably linked. You cannot separate one from the other. So this is why I say that health literacy, it's everyone's business. So very quickly, a little bit about the Health Literacy and Rehabilitation Project. It's an implementation science project. So we're not seeking to generate the new information about health literacy. What we're looking at is a way of implementing the best available evidence to see how it sticks in practice. It's team-based, and it's based around a team connector, someone within the team who's going to be the key connection between the project deliverers and the people in the team. What we do is we individually pre and post test the members of the team who are involved to see how their health literacy skills and knowledge changes throughout the project. What we do during the project is generate bespoke education that we give to the team. And we talk about creating a team's bespoke toolkit for health literacy as we go through. And it's taken, for the first two teams that we've worked with, it's taken about 6 to 8 months to go through that process. So we've had 2 teams already. I've just started with the third team, and I'll probably be looking for expressions of interest for a team to join me next year to be the next team to go through the health literacy and rehab project. So that's my introduction to health literacy and the project. I just want to flash up there all the people who've been involved in the project so far and the funding support we've received from the Hopkins Centre and NISQ and in kind from SPOT. And I just want to also mention thank you to Mikala for all the work that you've been doing behind the scenes to help get a little bit more funding to keep this going. So now I'd like to hand over to Rhonda Beggs, who is going to do the next part of the presentation. Rhonda's the team manager for the newly instituted Intellectual and Developmental Disability team in Metro North Mental Health. Rhonda's a very experienced practitioner in the area of intellectual and developmental disability, and I'm so grateful that she's here today to explain to you a bit about easy read materials, because something we found through the Health Literacy and Rehab project is there tends to be some confusion about what easy read materials actually are, how they differ from plain language, and the way that they're used. So over to you, Rhonda.
Thank you very much, Delina, and can everybody hear me? Excellent. All right, so thank you for that introduction. I will get started. So Metro North would like to acknowledge the traditional custodians of the land upon which we work, live and walk, and pay our respects to elders past, present and emerging. And I'd particularly like to acknowledge as well the lived experience of those with intellectual disability and mental health conditions from a First Nations background. So today I'm going to help think through who easy read materials are for. I'm going to think about understanding the similarities and those differences between easy read and plain language materials, and what that might look like in practice when we're thinking about those principles. So easy read and versus plain language, when we're thinking about those, as Delina's already mentioned, we really want to think about the usability of it and the understandability of those concepts. So usually when we're thinking easy read, we're thinking about giving information and supporting information understanding for those with an intellectual disability, people who are not familiar with English, and people with significantly low literacy levels. So what I'm going to do is just to take you through some of the ideas, and we'll have a look at some of the examples that are out there, and then we can kind of tease apart some of the elements of them that may or may not be helpful to you. So what I'd like to say first is that not all easy read materials are equal. So you'll see many things touted as easy read, but then when you actually delve into them, you'll see that they're really different. So here I've got 3 examples, and on the left-hand side of your screen, you can see that there's information about carbamazepine. That's a medication for epilepsy. And this is an easy read material. On the right-hand side of your screen, you've got another version of easy read material for the same medication, actually. And you'll see again that there's some differences in terms of setup, in terms of how the words are used and how the pictures are used. In the middle, we've got an easy read example from the NDIS. And you'll see there that that's different again. There's no pictures, for example. The font is quite small. So we can see here that there's differences in interpretation. And what that comes down to very often is thinking about who you are creating these materials for. So let's just have a think of some of those elements and how we might engage with the audience, which of course is the purpose of the easy read material in the first place. This slide is deliberately chaotic. This is not what easy read materials should be, but this helps us to think about what we need to do when we want to communicate written information, easy read materials, to our audience. First and foremost, we need to think about who the people are that we're delivering this information to. So what do they need? What are their needs? What do they find challenging around reading materials and understanding materials? And what are the strengths of the group as well? Typically, easy read materials uses lots of white space. It needs the information to be very clear. In the middle there's a picture, and I don't know what you see. Do you see the overarching face, or do you see the tree and the smaller whole person? Easy read materials use pictures that carry information. The pictures that carry information need to be clear, non-ambiguous, and absolutely relate to the material that's written there and overarching key message. Any difficult words, like anaesthetist, need to be explained. We need to be mindful of text effects and how we use font size, effect, and colour to really get over the message, but also to have consistency and to minimise the demand on the people that are reading this information and using the information. And above all, we should make sure that we have uniformity of purpose. And with that comes the idea that we're information giving, not asking demands of the individual. So as a general rule, easy read materials don't ask questions of an individual. And if they do, they help the person by minimizing the demand, by giving them some examples of the answers. So let's look again. Not all are created equal. And as you can see here on the left, we have not very much white space. And in fact, the carbamazepine information is put with a yellow text block background. That might be really quite difficult for some people to use. On the right-hand side, you can see that there is a picture that indicates each of the words, and that's probably a bit more clear for people that are using that information. Now let's go to this as an example. This example here has a direct link between the picture and the words. You can see here that the word vaccine is in bold because it's a more complex word, and there will be, and is from where this example is available, a glossary of difficult terms. You can also see that there are people with real pictures and photographs. Depending on who you're aiming for, you'll want to consider whether you want to have pictures or indeed stylized versions of individuals and people. Two different thoughts on that, and you will go with the expert group. And that's an important part of this. When we're designing Easy Read, we need to think about the individuals for whom we're designing for. So to sum up, Easy Read, the idea is that we focus on simplicity. The text and the images both convey the meaning, and the meaning is intended to be read to or with the participant. So we've already acknowledged that Easy Read materials are for groups of people who find literacy difficult or who may have very, very low levels of literacy. In general, we will have large amounts of white space. There will be a large font size, typically 14 or larger, and it will be Public Sans font equivalent because that's easier and it has less ambiguity. It is considered to be a summary of the source materials, so not every minutiae is captured in that material. We want you to give a broad outline of this because it's intended to be supported communication. And overarchingly, that's the difference between that and plain language materials, which typically give a more in-depth discussion and explanation, and usually can be read by the individual. So I hope that's given you a brief overview of the summary. Most importantly, I would suggest that if you're thinking of developing any Easy Read materials for your area, really involve your service user cohorts for whom you're involving and designing for to give you some ideas. And I think I'm on time. Thank you very much.
Thank you, Rhonda. That was fantastic. And yes, perfectly on time. And I found Rhonda's insights very useful in helping me to understand the nuances between easy read and plain language. So I hope it was helpful for you also. Now I'm going to call on Holly Booth, who is an advanced physio with the Spinal Outreach team. Holly's going to give us a practical demonstration of how she uses whiteboard for patient consultations. Now, we've pre-recorded this little session because we found it was easier to show you what was happening on the screen and to see the pointers by doing so. So I'm going to hand over to Holly now, and she is going to share her screen with you.
Sorry, hello everyone, voice is now on. Just going to quickly share that screen with you and the video. Okay. So hopefully if people give me a little thumbs up if you can see that now. Yep, perfect. Here we go, we're going to press play.
Hi, Holly. Thank you for agreeing to take us through the basics today of Microsoft Whiteboard and to give us some examples of how we might use it to improve our clinical communication. So take it away.
Thanks, Delina. So Delina, you and I are in a Teams call at the moment, a video call, and Microsoft Whiteboard is another app that you can actually use whilst you're in Teams to aid communication. So to access Whiteboard, you go up to the top here where the share icon is. Because I have used Whiteboard before, you'll see that Microsoft Whiteboard is an option for me to open straight away. If you have not used Whiteboard in Microsoft Teams before, you need to go to Apps. You can then search for it in the search bar here. If it doesn't come up immediately, don't get worried. Go down to the bottom here where it says Get More Apps and search here. You will find it and then be able to use it to aid your communication in your calls. So I'm going to go back now to share and open a blank whiteboard, and then we'll talk a little bit about how the main features and then how clinically we can use this in Spot. So you'll see that Delina and I can still see each other, we can still talk to each other, but now we have a white screen where we can paste pictures, we can write text, and add to our communication visually. So along the bottom here, you'll see there's a lot of little icons, and these are your different features of how to use the whiteboard. So that triangle is your select tool. The hand means that you can grab the whiteboard and move it up, down, sideways. So if somebody has put an image up and it's just out of your view, you can move the screen. You can also use the scroll button in and out on your mouse to zoom in and zoom out to give you an overall picture of things that are on the whiteboard.
And I can do that too, can't I, Holly?
You can,
So
Delina.
I can
So
move
there you
my
are. You're up on the
cursor.
screen.
Yeah.
So anyone, if you have multiple people in the call, they'll all have a little icon. You can turn that on and off up in settings if you don't want people to have the ability to change things on the screen. But it's nice if you can all be interactive together, and then you can see whose cursor is where and who's drawing and writing, etc. So yeah, you have the drawing options where you can draw shapes, etc. The next one along is great for brainstorming sessions. You use post-it notes of different colors and you can type on them. It will tell you who's typed that message, which can be really useful for kind of brainstorming. There's emoji reactions, you can write comments, and there's text. So I'm going to actually put up here for the little clinical example I'm going to use. I'm going to write Mr. J's skin, so that there is a heading at the top of our whiteboard. I'm just going to delete a couple of these bits that we've just drawn. And then the three dots at the bottom there, you see you've got more options. So there you have the ability to add in videos, images, documents, links to other websites. There are some preset templates you can use, also meeting-based templates. So I'll let you all explore that later at a later time. But to give you a bit of an idea of how we clinically use whiteboard when we're doing video conferencing and Spot. An example we often will have is that a client will call us or email us and say, hey, I've got a wound and I'd like some advice about it. So they'll often then send a photo to us. I'm just going to bring one across of their wounds. So we could paste in that image so that then we can talk to the client a little bit more in detail whilst that image is up. The advantages of that is that our clinical nurse might be able to then draw on the wound and say, hey, I'm a little bit concerned about this darker border of the wound here, or point out specific things that they might want them to work on in that wound or to focus on. They may also then put some information about dressings. I would like you to use this particular type of dressing. Control V, like copy paste, it works as well as using the paste icon. Sorry, that didn't come across. So yeah, they could put in some information about different wound dressings. They might have a link to those that they want to add. You can aid your communication, your education. So for example, we might put in a picture about pressure ulcers to explain what stage this wound may be, to aid that education. We then may say, hey, we also have this great new website, the QSIS Knowledge Hub, and I'm going to send you a link to the skin section that goes through a lot of information about managing your wound and offloading. And so I could go down here and add that link, and then that will come up as an active link that all the participants in the call can access. As the physio on this call, I might want to be talking about positioning in bed and how to offload the wound, and that can be hard to describe in words in a phone call. So it can be really useful to aid communication with a visual of that. So I might then pop in a picture of positioning to offload that wound, to where to put your pillows, how that may look in terms of offloading that hip. So it really is a way to provide that visual as well as your spoken communication to just aid understanding.
That's great, Holly. Thank you for that. Just as we wrap up, can you tell me how you would then share this screen or how you would keep it for future reference?
Yeah, so there's a couple of options here. Everyone who is in the Teams call will have access to that whiteboard. If they open their whiteboard app later, that will automatically save for them on their within their whiteboard app. You also have this icon here, the little square with the triangle in it, which is share this whiteboard. So if you open that up, you'll be able to add an email address and share the link to that particular whiteboard. The other option you have is up here in the settings menu, that export at the top. You can actually export it as an image, save it in the client folder. I sometimes find that really useful if I need to do my documentation a little bit later in the day and I just want to remember everything we went over in that call. Bring up the image, it reminds me all the things we discussed and can aid with that documentation in the medical records.
I guess the only thing about that would be that once it's a picture file, then the links wouldn't work. But I guess you can still see the QSIS website and search, or go through one of those other methods, go back to the whiteboard.
That's right. And an example we used recently was I opened Whiteboard later and then actually just popped those pictures back in as a summary email and included the links as well. Just remembering what we talked about. Here was the plan we came up with, and that made it really easy for me. I didn't have to go searching for those links or images again because they were already saved in Whiteboard.
That's great. Thanks so much, Holly.
Thank you. Okay. And so that's the end of that section.
Thanks so much, Holly. Thank you for persevering to get that recording to work. We had some considerable technical difficulties, and apologies if that was a bit blurry. from my end, it's sort of, I think it's just internet connection issues, but hopefully people could follow. So while I'm queuing up my part of the presentation, which is about writing better emails, I'm just wondering if anybody would like to write in the chat and let me know whether you're using whiteboard at all in your clinical communication, because I know that it certainly Spot, after the health literacy and rehab project, are certainly embracing it. So thanks, Holly. I'm just going to queue up for my next presentation and see if I can, in fact, bring myself up on the screen, which I wasn't able to before. Unfortunately, I am still... Unfortunately, I can't bring up my image, so I apologise. Go. It's just a little slow to load.
How are you?
There we go. We've made it. Okay, so I'm just going to give you some quick hints and tips about writing better emails for clinical communication. So what's a better email? Well, basically it's one that's opened for a start and then acted on. Now, there is quite a lot of research around how to write an email to get it opened and acted on. Much of this is in the business space, in marketing, but also in health, public messaging and so on. And what we need to do when we're thinking about writing better emails is to extrapolate or draw on that research to think about how we structure our emails to make them better. So when I'm talking about writing better emails, in my head, I'm thinking about clinician to clinician emails or clinician to client emails. But really, you can use this information to write better emails in any circumstances. So this is a little cheeky. I call this slide "Do Unto Others." So if we're talking about writing better emails, a great place to start is to think about the kind of emails that you hate to receive. So here we go. I enjoy getting long emails that have little punctuation, lots of typos and redundant sentences that run the full length of the email screen, have next to no formatting. If I get emails like this, it makes me think that the information isn't very important, and so on and so forth. I won't keep reading it, but you get the picture. So something we know from the research is that if an email is poorly formatted and has typos in it, people psychologically think that it is less important. It's just a natural psychological reaction to the receiving of that email. If the information in the email is dense, then it will more than likely go to the bottom of an email pile that need to be acted on. So we need to do things to the structure of our email so that psychologically people recognise that it's important, and also that they can read it quickly and they can act on it. There is a lot of information around about writing better emails, but I've distilled this down to 3 things. The first thing is to determine the goal of the email. I think this is a really powerful place to start. Why are you sending the email? What do you hope to get from sending the email? And this goal or purpose, you need to convey this really clearly to the recipients. It seems kind of obvious, but there should be a purpose in the email you send, not just flying off with emails here, there, and everywhere. I think that's more what we do or see in communication with text messages now. Emails can come back into their own. They really are a great means of communication if we follow some of these principles. Principle 1, determine the goal of the email. Principle 2, it's pretty self-explanatory. Less is more. Reduce the words. Reduce the number of sentences. Keep it simple. Include fewer ideas. Now, what the research shows is if you have multiple ideas that need to be absorbed, you are less likely to get any action, or you are very likely to get action on one idea and not others. So you need to put a limit on the number of requests that you make in your email. In fact, the research shows that you're better to break up requests instead of putting them all into one email, to actually break them up into separate. Now, obviously, sometimes that's not going to apply in the context, but that's certainly what the research literature tells us. And the final thing, design for ease of reading. So there are some things that you can do to make the information in your email stand out. You've got to make the key information visible, and often that means bringing it up to the top of the email, or in this case, maybe using underlining or some other judicious use of highlighting or bold. If you use too much of the underlining, highlighting, or bold, it simply becomes a blur. You need to use this sparingly. You can also use space to separate ideas. One of the problems with emails is they do tend to run on, and they seem to generally have text that's very close together. There's not much line spacing. So as with all materials that are written, to make them easier to read and digest, more space or more white space helps. So just to recap those 3 things, determine the goal of your email and make sure that the goal is clear. Less is more. And design for ease of reading. So if you can remember these 3 things and try to do them when you're writing your emails, they will become better emails. So just to finish off, I'll show you an email that I have written up here. So at the top here is the subject line. The subject line is very important, and that's where you can put across your purpose. But I've also put the purpose of the email, which in this case is to confirm the next steps in the project. So I'm just going to read through now the whole email, then I will come back. Hi Jane, it was great to meet your team today. The purpose of this email is to confirm the next steps in the project. You will, 1, distribute participant information forms to team members. 2, ask each team member to sign a consent form and return them to me by post. I will send you a list of possible topics I can present to your team. 2, create an MS Teams site to make all project information easily accessible for your team members. Feel free to let me know if you need more information. Otherwise, I will wait to receive the consent form so that we can plan the presentation schedule. Okay, so it's fairly short. I've kept the sentences fairly short. I could probably even make it shorter if I put my mind to it and reduce more words. I've got these highlights here. You will, I will, So these are the action statements. So in terms of my requests, it's clear there that I'm going to do something and this is what I'm expecting you to do from this email. I've got the underlining there for next steps because that is the key concept. That's what this is all about. And then I finished off with another underline rather, which is what's going to happen, what the trigger is for me getting back to you. So I will wait to receive the consent forms. I've also used some bolding, but just the right amount. So you can see that you can look at that email and not even read it in full, but you're going to get the gist of what it contains and what's required. And the highlight only on those two things, not lots of highlight across it. And here's space. So you can see I've spaced it out. So that is a better email. Okay. Thank you for that. Any questions in the chat? I see there's a comment there about a case conference that was led by Holly, and that I assume it's the whiteboard was very helpful. And Kathy said you can see the benefit. Thank you for that. So now, to finish up, our last segment is going to be a chat with Amy Seymour-Jones, who's an advanced rehab coordinator. So I invite you to come on, Amy. Thank you. Amy is with the Acquired Brain Injury Outreach Service, and they're just about to finish their participation in the Health Literacy and Rehab project. And it's been a really great experience for me because the team's been very engaged and I've enjoyed working with them. I'm also going to bring in now Julianne Malt. Want to come on in, Julianne? Julianne is a CNC with Spot, who I've known for years and worked with. And it was in fact Spot where I first started with the Health Literacy and Rehab project. And one of the things about this project, because it's an implementation project, it's very iterative. So some of the things that we did with Spot, we learned from that, and Abios has benefited. And now I'm just starting with the West Moreton CBR team. And again, they're going to learn, they're going to benefit from what we've learned from both teams. So I just wanted to ask both of you a few questions so that audience can get an idea of the sorts of things that maybe you've picked up through the health literacy project. So I was wondering if you'd learned anything genuinely new. So I'll throw to you first, Julianne. Was there anything genuinely new, or was it really more about reinforcing things that you'd already heard about in health literacy?
I suspect it reinforced a lot of the stuff that I actually do in practice, because if you try and communicate with your clients using complex medical terms, lengthy sentences, and over wordy explanations, they tend to switch off. So you've got to try and be concise and short, and make sure you use plain language. I think one thing I actually did learn was that we do tend to over medicalize things, and we don't use plain language enough.
Yep. So yeah, you kind of revert to a way of speaking, and it's really a I think a conscious effort to have to try and overcome that. What about you, Amy? Was there anything that you think was new, or did it just reinforce things you were doing or highlight things?
I think working with people with brain injury that have changes to their cognition and changes to their communication, but also their families who are often, in places where they're very overwhelmed or in crisis. As a team, we've probably thought a bit about this already in terms of how we're communicating going to be most accessible and most going to support people sort of genuine understanding and participation. So I think a lot of it was very affirming, and it was nice to do it as a team and to have a shared kind of framework and language to underpin what a lot of us, I think, doing. I think what was new for me and I really found valuable was all of the tips and tricks around the technology, because that is evolving so quickly. So it was really lovely to have that time as a team to go through. But we all know about ChatGPT, but can you use it? How do you use it? How do you get the most out of it? Learning about quick parts in Outlook, so you're not typing out the same sort of explanations to people about QCAD or fatigue over and over. You've sort of got that ready to go.
Great. Yep. So really practical things like that. And you are so right. This space is evolving so rapidly. So the use of AI in health literacy, production of materials, and looking through your materials to improve them, just changing week by week. Amy, probably to you now, what do you think were the biggest opportunities that were identified in Abios in terms of building on your health literacy responsiveness?
Just in a comment in the chat to speak up, so I just want to check everyone can hear me. I'll lean a bit closer to the microphone. I think one of the first things we did with the project was think about how we're already contributing to the health literacy environment, where the opportunities were, where the challenges were for us as a team, so we could be really intentional about making the most of the time with you, Delina. I think probably we were in the midst of updating our website, redoing fact sheets, so it was just, the timing was amazing to be able to think about how we could apply these principles to those fact sheets that we were redeveloping.
Great. And Julianne, what about Spot? What do you think the opportunities were that were identified in Spot?
Well, we have added a health literacy toolkit to our SharePoint page with information. So things, we've got standard emails for Spot introductions. We've got some how-to guides and some nuggets that we can send people. At the moment, we've got nuggets for NDIS nuggets and skin nuggets that we are standardized things that we can send out to people that are already there, which I think is really good, and it's nice and it's accessible for us so that we can add stuff and update stuff.
So I think that would be my recollection, as well as the email. Consistency was a really big thing, and
we have an email checklist.
A checklist, yeah. And great that you bring up nuggets. I think we called them chunks in Abios when we were doing it. Nuggets, chunks, whatever. They're just little pieces of information that, as clinicians, you might be using them over and over again. So it's really worthwhile thinking about, and you probably already do this. You've already got particular ways that you write to express or verbally express certain things, but you can really nail that down and get it so that it is usable over and over again, and that you've put a lot of thought into it being as plain and clear as possible. Julianne, do you think that there's been, and it's been a little while now, are there things that you think are a bit different about how Spot's approaching clinical communication?
I think we're certainly all very cognizant of making sure that our communication is very, it's more concise, more clear, it's more patient focused, and we also try and making sure that our clients and whoever we're working with understand what the message is that we're trying to get across as well.
So you think that has really embedded that sense that you need to check in with people?
Yeah. And I think also some of the stuff as well is we tend, where we used to always say, oh, I'll call you back in 3 weeks, or we'll touch base again in a couple of weeks. It's sort of, we also tend to put the onus back on the clients and their families. It's like, okay, you will come back to me in 2 weeks. If I don't hear from you, then we'll consider that this may be resolved. So it's sort of giving some more clear boundaries as well for who's going to do what.
Yeah, no, that's a great insight. Thank you for that. Amy, is there anything you think that at this point is, altering in the general team approach?
I think we're working our way through it still. but I think it's definitely forefront of people's minds, and we're
Yeah.
talking a lot more about health literacy, responsiveness as a team, individually and at meetings and that sort of thing. I know personally for me, there's things that I'm doing differently now because of the project, which has been nice.
That's great to hear. Thank you. Now, my final question, we've talked about lots of positive things, but, I know that there's some things that don't always work out so well, and there's barriers and so on. So, Amy, are there any barriers that you want to bring up? Like, what stands in the way, do you think, of all this information about how to do better clinical communication? What stands in the way of implementing it?
I think sometimes it takes time to learn a new way of communicating. So, you could tap out an email very quickly, but when you have to think about, I need to apply these principles, it takes longer to be comfortable in doing that. But I think the more you do it, the better that comes as well.
Yeah, so there's time that is required, and there's some effort that is required to make the changes.
Yeah.
Yeah, thanks. What about you, Julianne? What do you think? Are there things that are stumbling blocks, and got any ideas how to overcome them?
I think I tend to agree with everything that Amy said. I think one of the biggest stumbling blocks, well, it's more of a comment, is we do still have a portion of clients that aren't in any e-age. So they don't have access to computers, they don't have a mobile phone, they don't have email. So trying to make sure that we capture those people, I think, can sometimes be quite tricky, because you might actually have to go against everything and send a very lengthy, detailed letter or information so that they can old school, so they can get the information.
Yeah. I think that you've touched on a very important point there. We've talked about health literacy today, but a concept that partners with that is digital literacy. So people and digital access. So some people don't have digital literacy, they don't have digital access. So we need to be flexible in the way that we deliver this health information to take regards for that. Before I wrap up, any last comments, Julianne?
No, it's been an interesting project. It has been interesting.
Thank you. And Amy?
No, it's just been great to be a part of.
Thank you so much. Now, in our last few minutes, I'm just checking to see if we've got any questions or comments here. And I think a great one here from Melissa Kendall and Abios, that something that is important that she believes is even old dogs can learn new tricks. And you don't have to be perfect, but it does increase your awareness. So you don't have to write these things perfectly. Thank you, Melissa. That is a great comment, because I think that there's been some anxiety created around producing plain language materials, that we must get it to a certain grade reading score. And that's one of the reasons why I titled my little presentation Better Emails. So we're just striving to be better. We're not striving for perfection. We're just trying to do better than we were before. So if you think of it in those terms, don't sweat it. Don't stop trying because you can't achieve a certain perfection in your plain language in terms of the grade reading score, but keep on plugging away. So I don't know if there's any other questions I've missed there, but feel free to contact me or contact the Hopkins Centre if you'd like some more information about the things that I've discussed and the presenters have discussed today. So if that's it, I'd just like to thank you all for attending today's event, and we hope you found it informative. And as I say, please get in contact with the Hopkins Centre if you'd like to connect. Thank you again, and enjoy the rest of your day.